Welcome to the Cardiac MR Learner Series, a unique video tutorial program under the aegis of Indian Association of Cardiac Imaging. This program is focused on beginners and intermediate images, with learning happening through short sessions and case-based discussions. We are grateful to experts from different parts of India who have helped us in putting this program together. Please do feel free to give us your feedback so we can continually improve such training opportunities. This session is brought to you by Dr. Nilay Nimbalkar, who is the founder director of Precision Scan and Research Institute, Nagpur. He is a lead radiologist for CT and MRI in 7-Star Hospital, Nagpur. He has expertise in cross-sectional body imaging and is the lead radiologist for cardiothoracic imaging and angiography. He also loves pediatric cardiothoracic imaging and non-vascular guided interventions. He is been a guide for radiodiagnosis diploma course at Precision Scan and is an executive committee member of the Indian Association of Cardiac Imaging. He has conducted multiple CMEs on cardiac imaging and workshops for both doctors and technicians.
Welcome to the lecture of CMR assessment of mass lesion. I am Dr. Nilay Nimbalkar from Precision Scan and Research Center, Nagpur. Let's first see a few facts to remember about cardiac masses. Primary cardiac masses are rare. Most common malignant lesion in heart is metastasis. Most common benign lesion is a pseudotumor, and infections can mimic cardiac masses. Like all tumors in our body, cardiac masses also have predilection to a chamber or present at a particular age, like shown in the image. Pericardium having pericardial cyst or lipomatosis or liposarcoma or lipoma. Then the ventricle having fibroma, rhabdomyoma. Left atrium having myxoma, fibrosarcomas, osteosarcomas, leiomyosarcomas, undifferentiated sarcomas. Right atrium having thrombus, angiosarcoma, lymphoma. Valvular regions like fibroelastomas and vegetations. Metastasis, hemangioma, lipoma, and rhabdomyosarcoma have privilege to be present in any of the chambers. Similarly, few lesions present at a particular age group, like rhabdomyoma, are peculiarly seen in infants and children and has association with tuberous sclerosis. Then the sarcomas are adult lesions, exception rhabdomyosarcoma, which is again a tumor of infants and children. Myxoma is present predominantly from the 4th to 7th decade, and fibroma, which is a pediatric and a young adult lesion, is associated with polyposis syndrome. Moving forward to the scanning, which requires few changes associated with mass lesion evaluation on CMR. The routine sequences, as we all know through all our previous lectures, that need a small modification in cases of cardiac mass evaluation, which is addition of a special plane to suit the orthogonal sections of the cardiac masses. We can add tagging to see whether there is any pericardial adhesion. T1 and T2 double and triple IR sequences for better lesion evaluation, and add an early gadolinium enhancement scan with DI value of 500. With all preparations in mind, make the patient comfortable on the gantry and start the scan. So let's see at our first case. A 40-year male having pleural effusion and consolidation with a small mobile right atrial lesion on echo. Clinical suspicion of right atrial soft tissue or a right atrial thrombus was there. When we went through all the images, what we could evaluate is mildly prominent crista terminalis. No mass, no thrombus. Before reporting, we should understand importance of normal but prominent anatomical structures which may mimic a mass on echo. Crista terminalis, which is a crest between irregular right atrial appendage and an inflow sinus venosus part, if prominent, may be confused with a soft tissue lesion, but its anatomical location and signal intensity pattern similar to that of myocardium will help to differentiate it from a thrombus. Other few structures which may mimic a thrombus or a lesion are prominent comedian ridge, which is situated between left pulmonary vein and left atrial appendage, and a hypertrophic papillary muscle. Papillary muscle is obviously going to have similar signal intensity as that of rest of the myocardium, and with proper plane evaluation, we can differentiate it from any mass lesion. So coming to our case 2, which is a post-traumatic young patient, preoperative echo evaluations show suspicious lesion in RA with a clinical suspicion of thrombus first and then definitely soft tissue lesion in RA. What we see is a large lobulated hypointense intraluminal mobile lesion in the right atrium without any obvious attachment with the adjacent walls, and is extending in the right ventricle with the tricuspid wall during atrial systole and coming back again. So the point of contention here is whether this is a thrombus or this is a tumor. We took imaging planes to have better look at the extension of the lesion, axial, coronal, sagittal, to see the lesion properly in all the planes. It is appearing hypointense on both T1 and mildly hyperintense or isointense on T2-weighted images. Both early gadolinium enhancement and late gadolinium enhancement are showing hypointensity within the lesion and no contrast enhancement at all. So a lesion which is looking mildly hyperintense on T2-weighted image, showing no enhancement at all in the early and late gadolinium enhancement, has to be a thrombus and not a tumor. So what are the characters of a thrombus? A soft tissue showing above characters like early gadolinium and the late gadolinium enhancement. There is no enhancement at all in both the sequences, which appears hypointense, is more likely to be a thrombus. If at all a T2-weighted image is showing mild increased signal intensity, this may suggest presence of an acute thrombus. But the LGE in chronic thrombus may show some peripheral enhancement. A minimal peripheral enhancement of the clot can be due to fibrous component along its peripheral aspect, or it can be due to the blur pool along the lesion. In this case, what we can see is a soft tissue lesion which is nearly isointense to that of the myocardium on T2-weighted image, but hypointense on T1-weighted image. No enhancement at all in the early or the late gadolinium phase, but there is a rim of enhancement in the late gadolinium enhancement scans along its periphery, which may suggest a chronic thrombus attached to the wall. Another common condition where we see intraventricular thrombus is along the infarcted myocardium, which show hypo or akinesia, where late gadolinium enhancement will show enhancement in the infarcted myocardium with a lamellar thrombus which is not at all enhancing along the adjacent ventricular cavity. These thrombi are best seen on the LGE images and can be missed on SSFP images. Large acute right ventricular thrombus can also be seen in acute pulmonary embolism or cases of endomyocardial fibrosis, where an arrow-shaped enhancement along the endomyocardium can differentiate it from the other condition. This was a case of acute thromboembolic phenomena. Other conditions where CMR is indicated to differentiate myocardial lesion is focal hypertrophic cardiomyopathy, where it shows normal myocardial contractility with thinning and thickening in the diastole and systole, plus imaging characters absolutely similar to that of myocardium in all sequences, suggesting it as a focally hypertrophic myocardium and not a neoplastic lesion. So now we know the conditions and the structures which can mimic a cardiac lesion but are actually a part of normal variation or non-neoplastic pathology. So let's move towards something which is neoplastic. A middle-aged man with large LA lesion on echo. For further evaluation and diagnosis, echo diagnosis was kept as myxoma. Seen a 4-chamber and a short axis image show a well-defined ISO2 hyperintense lesion as compared to the myocardium along the left atrium, which is having attachment to the interatrial septum, causing indentation on the anterior mitral leaflet with mitral regurgitation. It appears mildly hyperintense on T2-weighted images and fat sat images, and it is showing isointensity to T1-weighted images with dynamic perfusion scan showing mild central patchy enhancement. The early gadolinium enhancement is showing minimal enhancement while the LGE is showing significant enhancement along the central part of the lesion and its attachment to the interatrial septum. The peripheral hypointensity, which may be representing a thrombus along its periphery, so it's obvious that it is consistent with echo-diagnosis of a benign left atrial lesion, more likely to be a myxoma. So what is important is to characterize a lesion properly, as some cardiac lesions have typical pattern of intensity which helps to reach to a diagnosis. Like the above example, which shows myocardial lesion appearing hypointense on T1 weighted images, no enhancement at all on the perfusion scan, but is showing intense enhancement on the delayed contrast enhanced scans. Such ventricular lesion most likely represent fibrous tissue predominance, hence a fibro. So you may refer to the tissue characterization charts in different journals for different lesions, and that can give us T1 values, T2 values, how the early enhancement and how the delayed enhancement. But important factors to be described in a lesion is whether this lesion is benign or is it a malignant lesion, whether this is a primary cardiac or a secondary cardiac lesion. We have to evaluate the lesion in all the axes possible along the orthogonal planes for the lesion, describe its character, describe how the lesion is attached to which wall, and whether this is causing any abnormality in the function of a wall or a cavity. Let's see another example where a large well-defined cyst is seen along the cardiac margin above the LAD stent which is recently placed. No contrast extravasation is seen in the cyst during the angio. No contrast extravasation was seen in the dynamic perfusion scan 2, and late gadolinium enhancement is showing a thin capsule of enhancement and water intensity within the cystic lesion with a well-defined thick wall, which was confirmed again by CT imaging, by CT angiography, suggesting a pericardial cyst with high proteinaceous content but causing mild pressure effect on the ventricular cavity. So describing a mass, describing its attachment is more important rather than directly reaching to a conclusion. So next, say a location of a tissue and characterization and considering age at which the lesion is presenting. This is a case of a 7-year-old girl with a right ventricular lesion appearing mildly hyperintense to myocardium on T2 weighted image and attached to the septum with a wide margin but showing motility with systole and diastole, and LG showing enhancement along its attachment and central part of the lesion. So looking at the age of the patient with intraventricular lesion, possibilities of benign lesion with a differential diagnosis of rhabdomyoma or a fibroma is kept, and evaluation for tuberous sclerosis and polyposis was advised. So make a checklist about description and anatomical relationship of the lesion, assessment of the size in 3 cross-sectional dimensions. Scene imaging gives its functional implications. Imaging characters on T1, T2, FATSAT images, early gadolinium enhancement and late enhancement is going to give us better visualization and interpretation of the lesion. Patient age, location of the lesion and imaging characters, leading to a closer differential diagnosis and not required to give histopathological diagnosis. So coming to our next case, a large soft tissue having transmural extension involving anterior, anteroseptal and anterolateral walls from the base to the mid-myocardium, sparing the apex with transmural involvement throughout its involving myocardial segments with mild pericardial infiltration along the lateral wall with minimal effusion. How are the margins? The margins are ill-defined. T2-weighted images are showing increased signal intensity. Perfusion scans showing early enhancement with both early gadolinium and late gadolinium enhancements and showing intense enhancement within the lesion with ill-defined margins. Is it crossing anatomical boundaries? Yes, it has gone to infiltrate the pericardium with enhancement as well as it is encasing the coronary vessels. The LCX which is seen along the left atrioventricular groove, is encased. So a benign lesion will never show or cross anatomical boundaries except if it is an infective lesion. Benign lesion will not encase a vessel and will not show ill-defined margins. And our lesion is showing all the features against it. So a possibility of malignant neoplastic primary cardiac lesion is kept as no history of other known malignancy was present in this case. So what are the characters we are looking for a malignant lesion? It has to have ill-defined margins. It is crossing anatomical boundaries. It is heterogeneous in enhancement, and pericardial effusion or pleural effusion can be present with areas of encroachment in those particular planes. It is important to remember that most common malignant lesion of the heart is a metastasis, and we will be seeing more metastasis than primary malignant lesion. This was a known case of CA lung with known metastasis into liver with myocardial lesion seen on echo. So CMR is showing ill-defined lesion along the lateral wall and the apex of the left ventricle, showing minimal peripheral enhancement on the perfusion scan and no enhancement on the early gadolinium and late gadolinium scans. The appearance is consistent with the other metastatic lesions which are also seen in the mediastinum and the liver, and it can be perceived as same malignant lesion or the metastatic lesion which is again seen from the primary which is present in the lungs. A metastatic lesion can be a direct extension from the adjacent structures like a lung, esophagus or a breast, or it can be a hematological or a lymphatic spleen. Please have a look at the pericardial effusion. If it appears hyperintense on T1 weighted images, it could be a hemorrhagic pericardial effusion. Not all pericardial effusions which are associated with a lesion is hemorrhagic effusion. It can be associated with benign lesions with maybe a pericardial chronic inflammatory process, but it could well act as a cause of discomfort and hence needs to be drained, as in this case of epicardial lipomatosis in an elderly lady with pericardial effusion. This was a wonderful case given by Dr. Richa Kothari from Narayana Hrudayalaya, Bangalore. A 4-chamber Cine SSFP sequence shows mass lesion involving biatrial valves and interatrial septum. Right-sided pleural effusion is present. A T1 weighted image, which is a image, is showing ISO2 hyperintense mass lesion involving both atria, interatrial septum. So it is crossing the anatomical boundaries. Stir images show heterogeneous intensity throughout the involvement of the mass. So the location, extension and signal intensity pattern and enhancement all are pointing towards a malignant process involving atria and ventricle. It is again showing intense enhancement on T1 weighted post-contrast images with infiltration of the vascular structures as well as the hilar structures as seen here. So a possibility of lymphoma was made considering the age and the encasement pattern, but biopsy, it showed fungal hyphae and patient responded well to the clinical antifungal treatment. So we should characterize the lesion, give extension, give closest differential diagnosis as we are reporting MRI images and not holding any microscope in our hands. So points to remember about CMR and cardiac masses. CMR is useful in cardiac masses evaluation for confirmation of presence of suspected lesion. Second, identification of a clot where early gadolinium enhancement and a TI value of 400 to 500 is going to help us. Describe a lesion, give its location, size, its motility with any functional significance and imaging characters. Tumor associated with complications, what complications are happening because of the tumor, we have to describe them. Assess features suggesting malignancy, give differential diagnosis, and you may not give a final diagnosis if it is not possible. Remember, chronic inflammatory or infective processes may mimic a cardiac neoplasm. Thanks a lot. Thanks for the patience.